is Dr. Charles. I'm sorry, I'm afraid I pronounce your last name wrong. If you please identify yourself, present yourself to us. Dr. Charles, are you with us?
Yes, I'm here. Can you hear me?
Yes, I can hear you clearly. Okay, you
Yes.
can
So,
start sharing them.
my name is Charles Adewale, and I'm one of the registrars, ST5 registrar, at Maidstone and Tunbridge Wells Hospital. I would start by giving special thanks to Dr. Nezrin Magdi for this opportunity, for telling me about this conference, and it's been really insightful being here with everyone today. So I will be talking about a case with the title Metastatic Non-Small Cell Carcinoma. But what really are you? It's probably a very long title, but I have chosen this title because from my little or not so little experience in histopathology, one of the things we learn when we are looking at EBOS specimens is to give the surgeons a diagnosis of whether or not it's a small cell carcinoma, because they can help them with treatment. But as I've progressed through my training, I've discovered the need to even further go down to characterize these cases, even in exam scenarios. So I would start by giving us the clinical details. Can we all see my presentation, please? Just want to be sure.
Yes, we can see it, and it transition smoothly and clearly.
Great. So we've got a 74-year-old woman with a significant smoking history who attended for a screening, and she had an incidental lobulated paratracheal density on X-ray. Based on these X-ray findings, she was sent for a CT scan, which showed multiple mediastinal and bilateral hilar lymph nodes. And because of this finding, she proceeded to have a bronchoscopy, during which multiple round necrotic lymph nodes were found in stations 4R and 4L. The largest measured 22 millimeters, while the 4L lymph node measured 19 millimeters. Samples were obtained from both stations for us to exclude sarcoidosis and cancer, which was what the clinical team were thinking about. So under the microscope, we had similar findings in both lymph nodes, which was basically scattered single and few clusters of cells, which appeared epithelioid. There was moderate nuclear enlargement and pleomorphism. The nuclei for most of these cells were central, but a few of them showed some eccentric positioning, and they had prominent nucleoli and abundant eosinophilic cytoplasm. On higher power, we can
I'm sorry,
appreciate
Dr.
the...
Charles.
Yes.
Which slide are you in now? We are on the
Um,
second slide now.
no, I'm on slide 4 now.
Okay, we didn't see any transition to next slide. We are on slide 2.
Oh my days. Is it? Can you see slide 3 now?
No.
I'm going to stop sharing and just do it again.
Okay.
Please bear with me. Okay, can we see slide 3 now? The slide with an image on the right side.
Yes, we can see your slide, slide 3.
Okay, great. Thank you very much. So I was describing these cells in this picture. I've said they're mostly single scattered cells and occasional clusters of epithelioid cells. There was moderate nuclear enlargement and some pleomorphism. The nuclei were predominantly central, but a few cells showed eccentric positioning with prominent nucleoli and abundant eosinophilic cytoplasm. On higher power, we can appreciate these cells a bit more better, and we found a few of the cells had pseudo inclusions and there were occasional scattered mitotic figures. Again, back to first principle, as we all know, we were confidently able to tell the clinicians it's a metastatic non-small cell carcinoma. And usually the plan is do a limited panel because we're trying to preserve as much tissue as possible because we might need to do molecular studies. So we started with a basic panel of a P40, a CK7, a TTF1, and S100 and melanine were thrown in just because of the description and the morphology of these cells to exclude a melanoma. Doing this panel of 5 immunos left us with more questions than answers, as all these immunos came back negative, and we had to proceed to do a broader panel of immunohistochemistry. A pancytokeratin came back positive, We had hepatocyte-specific antigen also come back positive, and this was done just because these cells morphologically looked like hepatocytes. We had positivity for EMA, and the other immunohistochemistry done in this panel, including HMB45, SOX10, SMA, desmin, WT1, calretinin, and OCT3/4 all came back negative. So we had some answers here at least. We were able to say yes, with hepatocyte-specific antigen coming back positive, it might be something hepatic related, but we couldn't confidently say that's the answer. But we were able to pin down our diagnosis to two diagnoses, which could be metastatic hepatocellular carcinoma or a primary hepatoid adenocarcinoma. Considering how rare a primary hepatoid adenocarcinoma is, we couldn't just sign that out without doing further immunohistochemistry. So we did a third panel of immunohistochemistry, which included CDX2, which came back positive. CK20 and AFP came back negative. Based on that, we were able to conclude that because of positivity of CDX2, the features are more in favor of a primary hepatoid adenocarcinoma rather than a metastatic hepatocellular carcinoma. However, we advise clinical and radiological correlation, especially radiological correlation, because we needed to know if there was any other finding on imaging. So we discussed this case at the multidisciplinary meeting, and the radiologist gave us information about the patient where the CT scan was consistent with a left upper lobe lung primary malignancy, and they gave us a radiological staging of a PT2A, N3, and M1B primary lung malignancy. However, at the MDT, we concluded to have a liver MRI and to carry out a serum AFP. Following the MDT, the patient underwent an abdominal or liver MRI, which showed multiple benign small cysts and a small cavernous hemangioma, but there were no sinister focal liver lesions. And the MRI also showed bilateral basal lung and left adrenal metastasis and a tiny 6 mm subcutaneous nodule along the anterior abdominal wall, which was suggested to be a possible subcutaneous metastasis. So we concluded this case by saying, based on the abdominal features, abdominal MRI features, and what we've seen on morphology, it was most likely a primary hepatoid adenocarcinoma of the lung. Again, these cases are very rare, and as I speak to you at the moment, the patient is still currently undergoing further workup for further management. But I will discuss very briefly the topic of hepatoid adenocarcinoma of the lung. Just as the name says, hepatoid adenocarcinoma, it simply means it's an adenocarcinoma which is liver-like, but found in the lung. However, it was first recognized as a gastric tumor in 1985. And one of the reasons why this case was difficult to diagnose for us was because it's very rare. And as I speak to you, it's currently still not present in the WHO tumor classification of books. And traditionally, when it was first described, it was defined by morphological features similar to an hepatocellular carcinoma and an extremely high serum AFP level. It's a rare tumor and found in other sites such as the ovary, lung, gallbladder, and pancreas. As I said previously, this entity is not currently recognized in the WHO classification, and I did quite an extensive literature search. I think I found less than 60 cases of this tumor diagnosed. Initially in 1990, the diagnostic criteria were said to be typical acinar or papillary morphology of the tumor cells and a component that resembles HCC and produces AFP. However, the final diagnosis should be confirmed by histologic and immunohistochemical methods to differentiate between an hepatoid adenocarcinoma of the lung and the hepatocellular carcinoma. More recently, in 2014, the criteria for diagnosing hepatoid adenocarcinoma of the lungs have been modified to say that the tumor can be pure hepatoid adenocarcinoma or have a component of typical acinar or papillary adenocarcinoma, signet ring cells, or neuroendocrine carcinoma. And AFP expression has been said not to be mandatory for diagnosis as long as other markers are expressed. A few papers have also mentioned that elevated serum AFP might be a poor prognostic factor. And because of how rare this tumor is, there is currently no standard management procedure. However, for really small lesions, they can undergo a radical surgery, which can be followed by a platinum-based chemotherapy and or radiotherapy. However, despite all of this, the overall survival rate has been said to be very low. The take-home message from my short presentation today is, because the lung is one of the most common sites for extrahepatic metastasis of hepatocellular carcinoma, it's always important to do a clinical and radiological correlation before considering the diagnosis of an hepatoid adenocarcinoma of the lung. Special appreciation to Dr. Amit Goel from Maidstone Hospital, who supervised me while reporting this case, and to Dr. Nezrin Magdi for the opportunity to present at this beautiful international conference and to learn from everyone here. Hopefully, I'll be here again next year. Thank you very much.
Thank you so much, Dr. Charles. Interesting presentation. Thank you for your effort, and we are very grateful for your attendance.
Thank you very much for having me.